Well, I'm happy to see all of you here, and I'm happy to introduce our first speakers. Who's going first? No? Well, we have Sabor Shahzad, who is the Director of Pharmacy at USC Arcadia Hospital in Arcadia, and we have Suzanne Arnone, who is the lead IT pharmacist, and we have Sarah Kim, who is the operations manager, and they're all going to play tag team to talk to us for our first session. Thank you, Fred.
Thank you, Fred. Sorry about that. Okay. So hello, everyone. Good afternoon. Thank you for having us here today. I wanted to take a quick moment to thank the American Association of Pharmacy Technicians as well as the Executive Board for having us here this afternoon. And I want to thank you, our audience, for being here as well, for your membership in the association. And also, you know, it really shows you that you're committed and you're dedicated not only to the profession of pharmacy, but also to the people that we serve by keeping updated and being participants in events like this. So thank you for that. As Fred mentioned, our team is from USC Arcadia Hospital. Our presentation this afternoon will be around medication management, specifically medication errors and how to prevent them. So without further ado, I'll pass it out to Dr. Kim.
Thank you. Not this.
Oh, sorry.
How do we navigate this? Good afternoon. Should I use this microphone? Good afternoon, everybody. Again, we want to start with I want to start with a question. You know, how common the medication errors are. You know, this is audience participation encouraged. 1 in like 100, thousands?
Probably 1 in 1,000.
1 in 1,000? Okay. So the FDA announcing it 100,000 medication-related reports per year. So if you're excluding the weekends, you know, it's about 300 a day. And then even some of the shocking statistics say the rate's going to be run about 1 per patient per day. You know, that's pretty high. And also for some of the inpatient hospital, I don't know how many are working inpatient setting, but in inpatient settings, there's a stat says 10% of the hospital patients are subject to the medication error. So that's pretty high. And let's think about the costs, you know, for any drug, any adverse drug reaction, you know, for the treatment is 3.5 billion. That's like about 17 years ago data. So I'm sure that's going to be even higher. Today's talk, objectives, I'm going to go over a little bit. It's a definition of medication errors. We're going to go over an adverse drug event. And we want to identify different types of med errors and the cause of errors. And then discuss safe practice and then medication error reduction plan, performance improvement. And then review more of the common types of errors and then the cause, a lot of studies, you know, case studies to it. And identify stages of the medication errors and prevent strategies. You know, the strategy is a key point. How do we prevent the med errors? And, you know, of course, you know, we are a big part of it. So as I got presenting it, you will see where we are. So we want to start with a definition first, the adverse drug event. It's the Institute of the Medicine defines this definition, that it's an injury resulted from the medical interventions related to the drug, regardless of whether it's error reached to the patient or not, or it has been occurred or not. This definition of the adverse drug event encompasses the harm that is happening during the medical care, that is including but not limited to the med errors, adverse drug event, allergic reactions, and overdose cases. So, and then also the Department of Public Health, they choose these 3 specific drug classes that is common, causing the adverse drug event, and also they are more measurable. And then, so these are the 3 classes of the medication that's gonna be focused on for the adverse drug event review. Anticoagulation, as we all know, has a very narrow therapeutic. That's why the lab has to be drawn for patient on Coumadin. So those anticoagulation medication can cause bleeding incident. And then diabetic medications, insulin, for example, that can cause hypoglycemic event. Opioid, I heard that the famous speaker is going to be talking about the opioid overuse. It's all over the news that, that can cause the overdose, and then also can cause the respiratory depression and also the death. And then we're going to look at another definition of the medication error. What is the medication error definition? That's very important. Okay, so it's preventable events that can cause and lead to the inappropriate medication use or the patient harm while the medication is in control of healthcare, care professionals and patient or the consumers. The key for this definition I want to emphasize is the preventable. It is preventable event. And then another thing I want to emphasize is that medication error can result from any step of these things that we put it here. So we want to see how pharmacy plays a part, how the technician plays a part in this process of the medication. Selection and the procurement is there. And the storage, we all involved with the storage, put it into the medication in the right place. And then of ordering, transcribing by the pharmacist, preparing and dispensing. We're all involved with all this dispensing process, just as simple as putting in the label, but we want to see how significant that part plays in the medication use process. Administration is a big part, monitoring. So we'll go on with discussing more details on this process. So from this slide, I wanted to pointing it out that medication error can take place any of the steps of the process, but then, let's make it more interesting. Let's say the medication error take place in prescribing. When the physician enters the order, we'll create a scenario that he forgot to put the allergy information. Okay, and then that's error taking place at the prescribing step. And the next step, transcribing, where the pharmacist verified the order, pharmacist ignores that or unable to check it, by under whatever the circumstance. And then let's go to the next step, administration part. Administration part, unless nurse when the nurse giving the medication, they could have asked, this is a new medication for you. Do you have allergic to this medication, or have you taken this medication before? These are the simple questions they can ask a patient. But let's say nurse skipped that and the medication is given. Then this adverse drug event taking place from the prescribing step it passed through the transcribing, and then it went to the administration. So all the steps are, it's called the Swiss cheese process, that, every step it got missed, and then now the error reached to the patient. So all these steps are very straightforward. Only thing I want to mention is the monitoring thing. Monitoring thing might be not as simple. Like monitoring, think about like pre and post pain level before pain medication is given. That could be a monitoring. And then how about the blood pressure checking before blood pressure lowering medication is given? How about blood sugar check before insulin is given, right? All these things are part of the monitoring. And then the rest of the definition of the software administration, that part, right patient, right dosing, right route, right documentation, right region, it's the list is go on and for the administration related med errors. And this is one of the big portions of the med error actually. The severity rating. So NCC MERP plan put this rating based on the medication error outcome. So its severity comes from the near miss. Category A and B did not even reach the patient, has a potential for it. So if you see the I section, the error may have contributed, resulted in patient death. So, fatal, incidents too. In between there, missing medications. So the reason we have this rating is so that the institutions, when they follow the medication errors, they are consistent and more systematic rating of their med errors. So it's a rating. So this index really helps for that reason. We want to look at the common cause of the medication errors. Let's start from the prescribing section. Ambiguous, illegible handwriting, or ambiguous. Instead of oxycodone 5 milligram, let's say physician said 4 tablets. So this has become an ambiguous strength, for that. Medication nomenclature, look-alike, sound-alike medication. It's a big part that can cause the med errors, even from the different manufacturer. But you will hear more detailed stories when Sue's going to presenting it. Equipment failure. We are depending on the equipment quite a bit. Let's think about all this IV pump, KBA barcoding. So imagine the equipment failure can be a cause of the med errors. Illegible handwriting, transcription errors. That's why it's very important. Part of the transcription is when the physician ever, ambiguous. Let's start ambiguous order, and then when pharmacists fail to clarify their order, that become a prescribing and transcribing meta errors. Inaccurate dosing calculations, it happens when they calculate the drip, so that's why we have a lot of technology help that we're going to mention it soon. Medication unavailable, drug shortages, right? It seems like ongoing. It's going. I don't want to predict, but it's going to be forever. And then there's individual. There's a staff-related or the human factors. Excessive, we have worked too hard. Working too much time, too long. Labeling errors, inappropriate abbreviation, inadequate trained personnel. All this staffing related can be a cause of the medication errors. And I want to have this one understanding it. It's medication error. It's in the process, medication use process. And I want to pointing it out where we are in the pharmacy. First, prescribing. The physician enters the order. Computer, so it's a CPOE nowadays, all very common CPOE order enter. And the next step is the mixture and labeling. Here's a huge part for the pharmacy. And here's what we coming to place, correcting it, preparing the medication in the right place. Even just simple task as of putting in the label on the medication, checking the expiration date. All this thing is it's integral part of the medication use process, and that's where we come in. I'm just simply putting the label on the medication. It's not simple anymore because that process will impact the medication, patient safety. If you look at it right in the middle, it's a preventing medication errors. So that's the goal. Patient safety, that's our goal. And your job is very, very important, integral, very essential by looking at the process of medication use. All right, so the pharmacy part, and then scanning. Again, when administrationing it, this is where that, barcoding, KBMA, and then, number 4, another technology, checking data at the smart pump, IV pump checking, and then documentation. So technology I mentioned, I've been mentioning it, there's a great technology. With the help of technology, there's a safe practices that we wanted to make sure that it's every step of the way, there's a strategy put in place that, making it safer and then reduce medication errors. CPOE, perfect example, and they're transcribing it, get rid of the illegible handwriting, and then order set. It does help. Let's think about, hypoglycemic insulin drips prescribed, and then there's a D50, their protection is there for the patient. So those are the good examples of order set. The technology help for safe practices, and then smart pump. There's a mix and the minimum and maximum dosage. Even if nurse put the incorrect one, they will give a warning. And also, institution have a standard concentration of the drips, so that it's easier for the nursing staff to put the rates on that medication. Automatic dispensing cabinet also. It's good for the security, and it's really helping. Let's think about this way. Some of the med-surg nurses can only get to the medication only when pharmacists verify the order, right? So that's a big help. And the barcoding, KBMA, you already know all the benefits that reduce med errors. I want to talk about a little bit about, since we're talking about automatic dispensing machine, we want to talk about override. So when you think about the override, what do you think about override? So you need to go to the routine steps, and it's skipping it, right? So let me explain it this way. When the doctor prescribing it, and pharmacist has to review. Again, pharmacist at first dose medication must be proactively reviewed by the pharmacist. When the emergency happens, during the time of emergency, the nursing can skip this and then able to procure the medication from the automatic dispensing machine. So this is only for the code situation or rapid response teams. When the emergencies are there, they can procure the medication out of automatic dispensing machine without pharmacy verifies it. Think about pharmacy, what pharmacist verifies it? They check the drug-drug interaction, they check any duplication, they check any dosage that is above max. All this review, all this interaction are skipped, being overriding it. So that means there's a more potential for the med errors because of that. So that automatic dispensing machine override function should be only available for some of the different groups, charge nurse, lead, house soup, have different privilege for their different roles. And intervention must be inventories. Whenever there's a discrepancy, it has to do the inventory correctly. And then, narcotic discrepancy must reconcile before the nursing shift ends. I'm so excited about the narcotic discrepancy because that's part of my job. I can go on and on and on, but then, next speaker is waiting for us. So Dr. Severity is gonna come in and to talk about the next relate to the discrepancy.
Thank you so much, Sarah. Here, hopefully I can project on a volume for all of you here. First, let me just ask you guys a little bit, how many of you are in an acute care, inpatient, hospital type setting? You guys, that's good. How about ambulatory setting, outpatient clinic type of you? How about retail, mail order pharmacies, anything like that? Or any other settings? Private oncology clinic. Okay, how about you?
Community oncology.
Community oncology, okay, that's good. And how about you guys here?
Mental health.
Mental health?
Oncology also.
That's good. Okay, so that gives me some feel for the room because I want to make sure the examples we talk about are most relevant and you can really see how it relates to you. Where do you make a difference? How can you change the way you look at your workflow and look at some do's and don'ts and some medication safety practices? So when we talk about the tips for do's and don'ts here, most of these you see they're listed for nursing, but you have a role, very important one. When we are in a hospital setting, we're telling the nursing what not to do and what to do. Basically, when they go to a machine and they're pulling the pain med for a patient, don't pull it in anticipation that, oh, this is every 6 hours as needed, and just have it on you just so that you don't have to go and get it at that time, and don't walk around with that in the pocket, those kinds of things. But if you're in the acute care setting as a tech, what can you do? I don't know if you guys are aware, there's a med safety certification techs can do. There's a med safety tech and med safety pharmacist role in acute care setting that people participate on, and some of those in the care clinics as well. And when you are looking at these automatic dispensing machine cabinets reports, what can you look for? When was the medication pulled out? When was it given? If somebody pulled out at 12 o'clock and the medication is not given to 1800, where's that medication? Is that in somebody's pocket? Should you be aware of those types of people? Those kinds of things you should be looking for. And if you are working in one of the clinic settings, you of course want to make sure medication security is a big deal anywhere. You have the legal obligation to keep the medication secure, not only just because they're narcotics, but even non-narcotic legend medications, right? So wasting a medication, for example, most of the places where you work, they have a process in place. If you are going to witness somebody that they're going to waste a medication, that it be a nurse in an inpatient setting and you are doing a filling of automated cabinet in the hospital setting, or let it be in the pharmacy retail setting or in a clinic where it drops on the floor, you're gonna waste it. Don't sign off as a witness if you don't see them wasting. That's number one. Why do I say that? Many cases have been reported to ISMP in places where medications have been diverted. Something else was in the syringe, a water or normal saline drawn, and the other nurse is witnessing what they're witnessing is not a true waste because the medication's already been gone. So there are plenty of those types of examples and cases you guys can think of, heard about, seen it in ISMP, where you guys can make a difference. And those are the things you need to be aware of. Can someone name a strategy what they implement that prevents either a med error or prevent diversion? Anybody?
Can you repeat the question?
You can think of any strategy that you do currently at work where you have that practice, and because of that you decrease the medication error types, any type, or implement that as something that causes less of a diversion risk?
Well, I would say, because I'm in compounding,
Mm-hmm.
I know with one of the medications that I noticed, because what I tend to do is, even though I've done it for so long and I'm familiar with it, if it's a new strength that I know, if it's the same medication, for instance, I had a Conv2023 medication that I need to mix with fluid. I was used to the 150 milligram, and then I received the 420 milligram. But for me, regardless, even though I know it in the back of my head, I still tend to read directions first. And because I read directions is when I realized the smaller dosage required sterile water, and it was a single dose valve as compared to the higher dosage, which was a multi-dose valve and needed bacterial static water. So when I'm not there at work, because I'm the one who's always mixing, if there's someone there to replace me, I just make sure I leave a note that the two cannot be mixed, and they have to be mixed with different types of water.
So that's good. That's a good practice during compounding, but several of these exact same type of strategies you can look. Reading the label properly, knowing the difference between different products. This is why many of your tech certifications have you memorize brand versus generic, right? Because that's where the confusion might be too. Some brands, generics, name look alike and sound alike are, right? And we'll talk some of those in today's presentation. You'll see some live examples of what they'll look like. But that's exactly it. You can look at your workplace, see what is the whole, where can I change my practice or do a little more to make sure medications are safe. It's the right med, right patient, right dose, right time, right compounding, right solution, diluent, etc. So those little things, and you'll see some of them by very minute overlooks can cause some detrimental errors, and Sue's gonna go on. So Sue, I'm not gonna take away your thunder. You're gonna talk about that, right? Okay, so here are listed some of the policies or practices for safe medication use. Using standardized concentrations. In a hospital setting, for example, those of you used to having a specific concentration drips. This is whether it be a morphine drip, an epinephrine, phenylephrine, vasopressin, any of those acute type drips, you want to standardize concentrations. If you are a clinic type setting, you might have a formulary you have developed that is closed type formulary where you're dispensing certain types. Or if you're going to keep a specific strength, maybe from a different manufacturer that has does not have a lookalike of the other, so you don't confuse. Those are some of the things you can do. Tall man lettering, like you see, the example's right in front of you. I don't have to explain much, so that it pops out at you, you can see the difference. I kid you not, that hydralazine, hydroxyzine, that exactly happened to me about 15 years ago. I was taking an order from a physician who said hydroxyzine and wanted to give it for the blood pressure control. When I asked for the indication, they said blood pressure. I said, that's not it for. You meant hydralazine. He's like, I swear it was hydroxyzine. I said, nope, that's not it. But you see, this is how you can do just a little extra question, what it is for. And if it's stored right next to each other, there's a higher likelihood you'll pick one over the other, in a rush especially, right? And this, you might have even, those of you who work in the retail, some of the bins are right next to each other. You even pick a wrong strength sometimes, right? You're going in the H and you pick, and you quickly think what it looks like, and it's not, or somebody returned to a wrong bin, right? So those are the things. And anytime you have a question what it is for, look it up. That's what the reference is for, right? Take your time, right? Sometimes time is important in acute care setting, but other times it's the practice that makes a difference. Better be safe than sorry, right? And that's take your time and look it up, and you'll be surprised how many times you will change the practice, cause a preventive medication error from happening and really saving somebody's life. And again, we'll have some live examples to share with you on that. Hospital IV policy refers to administration guidelines. Typically in a hospital setting, those of you who work, but for the rest of you, these are the guidelines hospitals have developed for the nursing and other care providers to tell them this is how this should be administered. Does it need a filter? Does it need a separate line? Does it have a specific expiration dating? All that kind of things are in there. All right, now national patient safety goals are put out by Joint Commission. Each year they get revised, and those of you who look at them repeatedly or get them through emails and different venues, there are many of them, and they change. And one of the things that consistently stays in the medication use category is the medication reconciliation. Now medication reconciliation means at 3 different spots where the medication reconciliation must happen. At the time of admission, when the patient's coming from the outpatient to inpatient, you're admitting them. When the care levels change, patients moving from ED to ICU or ICU to med-surg floor, or at the discharge time, when the same patient is getting discharged and their meds need to be reconciled, what they were taking in the hospital versus what they're going to go home with. So when they come to community pharmacy, you might have even seen that in community pharmacies. They come with a Protonix prescription, and guess what they were taking at home before? Prilosec, but nobody told them to throw that away. The same patient goes home, they got Prilosec OTC sitting at home, they got the new prescription for Protonix. What do you expect happens? They take both, right? Yeah, my father guilty was that, so. He has done that, and I would reconcile every time I see him on and off. He's almost 80 years old, but I have to look at his meds every time, and same is true for many older folks who either do not get admission medication reconciled properly or on their way out, discharge medication. So you at the retail level, when you see a patient coming with a new script, take a look at their old profile. And even though they may not be picking up Prilosec that day, ask them, hey, Mr. So-and-so, Mrs. So-and-so, are you still taking that? By the way, this is a new one, you should discard that. That is a key message. And that's where you guys can make a difference. And you will be easily able to spot it, because guess what's gonna happen, right? When you enter that medication, there's gonna be a warning pop up. So those alerts are built in, whether in the community or acute care or clinic setting, they're built in for a reason, right? And that's to catch. And some of the duplication could be detrimental, and you'll hear that. Any questions so far? Are we good? Yeah? Awake still? All right, very good. Now, obtaining medication, his accurate medication history is the key at all of these levels that I just talked about. And there are some pitfalls people tend to fall into, and they haven't changed after these years of teaching medication safety. Guess what? When a patient comes to you and give you a list, you assume that it is right. It is what they're taking, right? But what they're giving you is a past 5-year list. And many of them they're not even taking anymore. Many of them doses have changed. Assuming that is the correct one, that's one of the pitfalls. Next one, assuming the prescription label is correct. And I'll tell you this, not to blame anybody, a patient coming in it's a 5th refill, and the label says so, and is incorrect because somebody overlooked an alert or didn't know the max dosage. It happened with me, I won't go into the detail, but we caught it on a 5th refill for a really 80-some-year-old for a neuromedication, which was 3 times the max dose limit. This was in my experience. And me questioning it, caught it, and the lady had been in a hospital in past 6 months 3 times for that reason. So question, if something doesn't look right, I tell you 99% of the time, it is not right. So trust your gut feeling. When you feel something is wrong, look it up, and you might be right that there is probably something wrong. All right, not making sure meds are not required, like we talked about, that they're destroyed. Let the patient know, hey, destroy the old, or if they have the old back, take it and let them give it to you to discard and waste it properly. This way you ensure they don't go home and retake that, or if they forgot, right? How many people know that patients are given the discharge instructions or even the drug information pamphlet from the main community pharmacy, and they go home and they do what with it? Exactly, right? So how many people read it? Not many. It's got some significant, really valuable information. So who's the key? You guys, right? Intake, taking their allergy, med history, looking at that profile, and as they are needing a counseling from a pharmacist, or you are telling them simply, hey, is this a refill? But hey, by the way, you got to throw that old one away. That's the key information. That's the key information. So remember that. That's you guys are going to make a difference there. Not doing a good discharge teaching, we also teach that at the hospital. Same exact situation happens. They come in with Prilosec, hospital has Protonics on formulary, guess which prescription they get out the door? Protonics, right? And they get that filled, and now they got 2. And same thing happened with pain meds. Same thing happened with any other blood pressure meds. And blood pressure meds, you give them 2 of the same kinds they're not supposed to take, guess what's going to happen? Whose grandma not breathing and on the floor, right? That's what happens. All right. So what Sarah talked about were different stages of the medication use processes, from the prescribing level all the way to the administration monitoring level. But essentially, there are 11 categories that NCC MERP has identified. And at these 11 categories, you can implement some safety strategies to make sure the use of medication is safe for the patient, and it is safe for and decreasing the healthcare costs, because many of billions of dollars are thrown in healthcare costs on adverse events alone. And Sarah, you quoted what, 300 errors a day?
Yeah, about 300.
Right? So that's a staggering number, right? Anyway, so prescribing is the first step where the physician is looking at the med and putting it wrong dose, wrong patient, wrong time, wrong route, wrong med, wrong indication. Or physicians may be confusing one med with the other, right? The next one is the communication. If you were taking a telephone order or listening to a telephone order in the community or in the acute care setting, a pharmacist, a nurse is taking a telephone order, repeating back that one, hey, I heard you say this, is that correct? That's where half of the errors happen. I tell you, one of the med that used to be called Capodex, Capodex, it was in market. And I took a telephone order, and I heard Casodex. Now, Casodex was 5 milligram, so was Capodex, and Capodex was brand new in the market. And I'm like, Casodex for this patient, do they have some kind of cancer or something going on? And I'm like, no, this is for this. I said, oh, Capodex. So this was an easy confusion. Guess what? Including me, enough people reported that drug manufacturers were forced to take that away, and the new brand name is called Dexilent. So the same drug is now back in the market, Dexilent. But these are the things that happen. You got to repeat back, make sure that it's the right indication. And if it's one of those look-alike, sound-alike, report it on the MedWatch on FDA website, because you can make a change. Each one of you can make a change. Compounding, you already mentioned what you do, but many errors till this day happen at our compounding level. Isn't that right? We see that wrong diluent, wrong solution, wrong med, wrong label. A tech compounds 5 meds to keep the 5 labels signed off. Guess what? The label swapped. One goes over the other, which is why 1 med at a time, right? We tell that. That's where it happens. Dispensation. You intended something but dispensed something else. Label says correct, but you dispense either a wrong dose or a wrong med, or even a wrong patient sometimes. How many times did that happen? I can tell you just this past month happened. So if it happens to us, if it happens in my career, it happens to all of you. And you guys probably catch this on a day-to-day basis and correct it. Distribution. Distribution is where you're stocking the medication in the wrong bin. You know, you got a med return in the retail, you put it in the wrong bin, guess somebody else is filling that. Out of the 100 tabs that are in there, 5 are wrong, and you pull them up and you put it, somebody else is gonna get that, right? Same thing happened in the hospital setting. You put it in the machine and it's a wrong med in the correct pocket. The pocket's supposed to have hydroxyzine, you put hydralazine, somebody's gonna pull and give that, right? That's exactly right. So that's what happens. So packaging nomenclature, this is where your look-alike, sound-alike comes, but also your unit dose packaging, right? If you have a bulk and you're packaging into unit dose, which happens in a lot of clinic settings, hospitals, and you put a wrong label, or wrong drug, or wrong expiration, somebody's gonna give that, right? Wrong label, wrong administration, like what Sarah mentioned, right patient, right dose, right time, right route, all of that matters. And education, did you do the education for the patient? Believe it or not, half the medication errors are caught at the education point. You're talking to the patient, you're either taking their history or counseling them about discharge or letting them know about their refill or a new med, and you discover this is not the right med, or this is the wrong patient, or wrong dose, or this doesn't make sense. So you do have systematic alerts in place to tell you what's going on, but education is the key. Talk to the patients, talk to people whenever they can talk to you. I mean, alert passed outpatient ICU may not, so you rely on systems, but in med-surg, wherever you practice, talking to a pharmacist. If you're a tech and a pharmacist puts an order, guess half the errors are caught by technicians because they're questioning the pharmacist. Hey, they take a label. It happened to me when I was a brand new pharmacist 15 years ago, and they were, look, they would come to me. Did you intend to enter this? This is not how I have seen. You're like, wait, how have you seen this? Oh, wait, this is a wrong concentration. It's too diluted or too concentrated. So those are the things. You guys are like the key. You question it. Somebody else is going to question them, and somebody else is going to be prevented from giving the wrong med the wrong way. Monitoring, like what you heard, not monitoring patient pain level before giving. Respiratory rate, blood pressure, if you're about to give blood pressure, or blood sugar and giving insulin. These two can attest to you how many times we look at that. Reversal agents used because they didn't check the blood sugar, gave a long-acting insulin at a bad time, patient did not have their meal, 4 in the morning, somebody's blood sugar drops below 50 and they had to reverse them with a D50. You know somebody can really die with that, and many have, right? You guys can take a look at it and prevent that. And those of you who are used to in stocking medications and looking at these labels, and if you're making, like you're compounding, right? You compounded a morphine drip, you know it's running 10 mLs an hour, it's 100 ml volume, and you made 4 hours ago and the nurse is requesting to send another bag. You should question, like, wait, that's supposed to, if they're giving 10 mLs per hour, it should last for 10 hours. Why am I getting a request? Guess what happens? You find out that the nurse programmed the pump wrong, it's infusing at a different rate, and somebody else has dosed off there, right? So you could be those key people. Something doesn't look right, speak up. Don't be afraid. Don't be embarrassed, because you may really very well prevent somebody's life from losing, right? Now, medication use, how it is used. This is more have to do with medication use and kind of retrospectively looking. So those of you who have IT systems generated, you can look at how many albumin were used, for example, for patients who were getting intradialytic hypotension, or patients used insulin how many times in a month, et cetera, et cetera. Those system reports are there for you to look at. Those of you involved in those administrative tasks can also look. But even in the use, like I just example mentioned, how is this being used? Is this making sense? Is the morphine drip every 4 hours making sense? Or is the drug you're about to dispense making sense? If you have dispensed one medication for blood pressure in the morning and the night nurse is not seeing that, or the patient took one and you're about to give one, and you ask the patient, did you take it? They'll say this morning, so the next dose is not due till tomorrow. Because guess what happens? You give that one again today and they doubled the dose today. And just this past month, we had that happen too, right? So what you think is gonna happen, it can happen. All right, now let's go back to MERP categories again. The prescribing category, I will not belabor this. Most of you already understand this. Prescribing related errors, right dose, right drug, right time. Adjusting the dose even if the renal function is not acceptable enough for that limit for the medication to clear. That means you need to cut the dose. This is where you collaborate with pharmacists and do that. but if something doesn't look right, speak up. Again, admission med rec, all these examples where physicians are just writing continue home meds, that's where the med rec has gone wrong, right? Nobody asked them what they're taking. Is the list right? And if you are in the hospital setting, med history techs, we have 2.5 FTEs who are doing that, like with the pharmacists. You believe it or not, we do about almost close to 400 a month medication reconciliation for patients, and out of those, almost 75% have errors. What does that tell you? You cannot assume it's wrong because majority are wrong. You cannot assume it correct. All right, packaging nomenclature, we talked about that. So what do you do in packaging nomenclature? Double checking high alert type drugs, are they packaged right? Example here is insulin multi-dose vials. If you are putting those in the Pyxis and out of the refrigerator, you're putting a 28-day label, is that correct? Is that the right type of insulin? There are 10 million types of insulin these days out there, right? All different combinations, long-acting, short-acting, intermediate. Are they the right ones? You have the correct label. And is the Lantus and Levomir the same thing? Or Novolin 7030, Humulin 7025, Novalox 7525, are they all the same? Does the patient need one or the other? Can you substitute one with the other, right? And one may think it is, but not everything is the same thing. And some make a marginal difference on the lettering or the dose, but make a big difference for the patient. All right, distribution, incorrect med we talked about, dispensation, this is another. Sarah talked about erroneous medication overrides as one type. Dispensation, when you're not looking at dispensing Coumadin and not looking at the lab level, INR, or giving a digoxin, not looking at the last dig level, or anticonvulsant like carbamazepine, and not looking at their last level, or digoxin. Many patients come to our ER have dig toxicity because nobody's looking at that level, and they come there like 5 times the limit of their dig level. So now you're trying to reverse them, right? So proper monitoring, and if you're dispensing, those levels are available to you, we need to look at that. Administration, this is where all, like what the Swiss cheese model Sarah talked about, the medication went through the holes from the prescribing to your compounding to dispensation, transcribing, and then finally got to the nurse's hand. What is the likelihood if it has missed all and gone through all these holes that it's going to go through this one too? What do you think? Highly likely, 1 out of 10, 5 out of 10, 10 out of 10, 6 out of 10, 4 out of 10?
3 out of 10.
Almost 7 out of 10, how about that? 70% of our errors fall in the administration category. Why? Because they've missed all those cheese holes too. So isn't that staggering? Isn't that amazing? I mean, that may be for institution. I would love to look at the world level where everybody else is there fall into. But that is really bothersome, right? So chances are, because somebody else is looking at it and say, hey, they must have dispensed it, it's labeled, it's verified, it must be correct. And we have few really high functioning, nurses who question. They said, no, this doesn't look right to me. I haven't seen that. But if it's a new grad, a new certified tech, or new certified nurse, guess what do? They let it go, right? So even if you're new and you don't know because you really don't know, still look it up. Still ask somebody. There's no shame in asking. There's no one person in the world that can say, hey, I know it all, right? Nobody does. So don't be ashamed of it. We need to acknowledge and embrace and learn our shortcomings and really prevent and keep our focus on the patient safety, right? That's where you guys will make a difference. So if you have that focus, you keep that in your mind, I bet you not only will do a better job, but you will drive much satisfaction out of your job like I do, right? This is why we teach this. Education, like I talked about, educating the patient, whether it's a pharmacist counseling or you guys taking the intake history or talking to the patient in the hospital med history, or just simply giving them the prescription refill and say, hey, so-and-so, just checking, you know how to take this, correct? Everything good? And it turns out some of them, you say everything good. They say, well, no, let me tell you this. And you discover something else. And guess what? In that situation, that med wasn't even the right one for that reason. And that probably was the reason to stop that med, right? How many of you know patients who take statins or cholesterol medications got muscle pain and don't ever complain? They think it's old age or something, right? I've heard that before. They got dark color urine going on, muscle breakdown called rhabdomyolysis going on. Don't ever complain. They attribute it to old age. I'm just getting old. Everything hurts, right? And you find out this is the adverse event. And if you ask, some would love to talk and tell you, right? They tell me. we do leadership rounds at our hospital and get what every time we go into the patient room, and they know we're pharmacists by background. They tell us a lot of things, which is out of the scope of this presentation. But anyway, monitoring. So of course, ADRs that happen, and many times is the monitoring afterwards can prevent. Even though ADR has happened or adverse drug event has happened, just you monitoring will prevent. If you give a wrong med, patient is about to go hypo on you or low blood pressure, you catch in time because you monitored, then you can give something to prevent, not after, God forbid, they have passed out, right? Narcotic monitoring, of course, because it's one of the categories where a lot of adverse events happen, besides anti-coag. So that's that black box warning where you should look at it. FDA has put out those black box warning as the most heightened warnings for those drugs, so that you make sure that doesn't happen to that patient. And many adverse events related to black box warning. So of course, these are system-based reports many places have, and they're voluntary reporting, but everything that even is a near miss, I would encourage you guys to report it. And allergic reaction, infusion, anytime reversal agent use, or any wrong patient, wrong med, wrong route you discover happened or didn't happen, or you prevent or mistook it, go ahead and report, and that's how you prevent the next one. What is your role in medication safety? And that's the key piece I want to leave you with before I turn it over to Sue. Sorry it took a little long there. But double check anything you don't know or you feel suspicious of. You guys are frontliners. Sometimes pharmacists may be busy, not catch that, and more than half the times it's the techs in the pharmacy that discover these errors. So I'll empower you guys to think a little bit more. Don't be shy. Speak up when something doesn't look right. Ask a colleague. Oral syringe versus IV syringe, errors have happened repeatedly. Oral was given IV and vice versa, right? Be familiar with your list, institutions, policies, see what those processes are. What are your helpers, the support, the systems, and the checks? And if you're still confused, always look up references like ISMP, CMS. CMS has a medication management or medication therapy management section. Look it up. Joint Commission has it. ISMP subscription, any pharmacist letter, or any other pharmacy text letter you guys subscribe to, any journals, look up. Keep yourself apprised of the new information that's coming out. Know the help you have and the references. Any questions so far? We good? Still awake? So they're all yours. Thank you.
Thank you, Sabor. So I would say that both Dr. Shahzad and Dr. Kim really laid out the key principles around medication errors and how to prevent them. What I want to do, the next step, is kind of give you an idea of, having known those principles, what you can do to take action in your own environment, wherever you work. And I'd like to share some examples that might be a little staggering. So let's get started on that. So, as Sabor mentioned, there are various resources out available to the industry, and one of them that I rely very commonly on in my work is the ISMP, so the Institute of Safe Medication Practices. It's a nonprofit organization that's run solely based on grant funding, and for the last 25 years, it's acted as an independent watchdog for medication errors. And most of their work is dependent on the fact that errors are reported, whether they reach the patient or are near misses. So again, to Sabor's point, reporting is everything in this case. This organization produces two vital publications, one being the ISMP safety alerts. There are two different categories of these safety alerts, one for acute care settings as well as community settings. Their next publication is their best practices, which are considered the gold standards in the industry. And so we'll just, I picked a couple of safety alerts as well as a few of the best practices to review. Now, with COVID-19 vaccine, there were many, too many to count, and that would take a presentation in itself. But I wanted to point out one that was reported to ISMP and from ISMP to the CDC, and that is with the vaccination record card. So we remember these cards early on that were sent out with the vaccines. Initially, when the vaccine was approved for use, there were 2 different manufacturers. There was Moderna and Pfizer. That's all we heard about, right? And those vaccines required a 2-dose vaccination series. Fine. So the card accurately stated that it needed a first dose and a second dose. And there was even a reminder at the bottom that says, don't forget your second dose. However, it didn't take into account the fact that Johnson & Johnson later, a few months later, had released a single dose. At that time, the CDC did not update the card to state so. So where did the errors come into play? There were patients who received a second dose erroneously. Those who had received the single dose ended up getting a second dose. We were relying on those who were administering the vaccination to do their due diligence in covering or marking off the second dose so that it was very clear to the patient that they didn't require the second dose. Overall, it led to a lot of confusion. So there was, in addition to that, in addition to the card, there were errors with wrong diluents, the wrong timing interval, and I'm sure many of you here also can speak to the errors that you saw as well around COVID vaccinations. An additional safety alert is around pharmacy automation. And this affected the automated medication dispensing cabinet. How many here, again, work with Pyxis or pharmacy automation? Okay, so feel free to chime in if you have an example as well. So this one is quite chilling, so I shouldn't smile too much about it. It was quite chilling. It occurred back in 2017 or so, but it's still spoken about today. It was quite newsworthy. It occurred in a hospital in Tennessee where a nurse had received an order to administer Versed or midazolam for the patient prior to an MRI procedure. The nurse went to the cabinet, simply typed in VE for Versed. When she did that, what she saw on the computer screen was first at the top was vecuronium, also VE, beginning in VE, and Versed. And in the rush that she was in, selected the first one, which was vecuronium. Proceeded to remove that from the dispensing cabinet and administer it to the patient. Now, what happened? The patient stopped breathing, became brain dead, and eventually expired, passed away. It's newsworthy because a couple years later, the nurse was convicted for gross negligent homicide, and it really shook the nursing community, and actually all of us in healthcare, as a matter of fact. And ISMP and other organizations who work towards medication safety and preventing errors felt that it was an unfair verdict. They felt that it would reduce the number of reporting moving forward because it criminalized honest mistakes. So that was a very scary instance. Another safety alert. This is speaking to the look-alike errors. Now we see this, whether it's a vial or a tablet or such, we see this from time to time in our own pharmacies, where different manufacturers, certainly the one on the left here is a picture of a vial of verapamil. It's manufactured by Excella, and the one on the left, manufactured by Westward, has the same cap color as the one on the left, the same vial size. The only difference here, though, is the orientation of the print on the label. Nevertheless, when all of these are placed in a bin, they all look the same. So we're grabbing based on color at that point. What does this lead to? It can lead to restocking errors, administration errors, and what the ISMP recommends is that hospitals and other institutions order from different manufacturers. But nowadays, when there's a shortage of just about everything, we don't have that luxury of ordering from different manufacturers. So what we've begun to really is rely on barcode technology, hoping that the nurse scans the medication before administering to the patient so that it recognizes the correct drug. So that was safety alerts. And now I want to touch upon the best practices. And the best practices are considered the gold standards. Basically, the best practices were a compilation of so many reported med errors that ISMP says, you know what, guys, everyone is going to have to meet the standard to be safe, to be considered a safe practice site. Initially, all of their efforts, ISMP's efforts, were toward the acute care setting, hospital settings. But now, over the last couple years, they've focused on community, ambulatory care, perioperative settings, oncology settings. So they're really looking at different settings where medication errors can occur. So here's one of the newest ones. So the community pharmacy best practices just came out this year, so it's really new. There are only 5 best practices at this point. But one that I wanted to highlight was the use of moving away from, actually they're calling for moving away from using teaspoon and tablespoon in orders and as well as on labeling to prevent confusion. They're asking us to use milliliters using the metric system to teach the patient how much they need to take of a dose. And this particularly affects our pediatric population when a lot of things are based on mLs or milliliters. And so what can you do in this instance is, using the teach-back method. Can you show me exactly, based on the oral syringe that you're going to hand off, how much should you pull back to administer? Making sure that they understand how much is to be given. Now, a couple of hospital best practices. Seems pretty easy, but weigh the patient upon admission. Not taking their stated weight or what they think they weigh, because it can always be different. Not estimating their weight. Of course, if it's in an emergency, you'll have to estimate the weight and dose the patient from there. And not relying on a historical weight because things change. Now, most systems, when you're documenting the weight, will convert automatically pounds to kilograms. And so the standard is to document weight in kilograms across the board throughout healthcare environment. And this goes to prevent underdosing, overdosing, etc. And then lastly, I believe that's 2 more. Sarah had talked about the use of smart infusion pumps. And those are the administration, these pumps that administer all the IVs and things that we send out, blood, IVs, chemotherapy, etc. And all of these pumps have software involved with them where we can set maximums and minimums and concentrations that a nurse can't exceed or else they get an alert. Initially, ISMP had requested that hospitals in different settings that use these pumps only focus on high alert medications, insulin, heparin, drip, etc. But now in 2020, they say every drug that's being given in an IV route has to run through this particular software so that it can prevent medication errors. And then last but not least is the newest best practice. And I think pretty much this summarizes what we've talked about throughout this presentation. Really is, they want us to address our vulnerabilities. Whatever setting you work in, wherever it is, you have the tools now, the principles. How can you make your place a safer place for patients, right? We're now the advocates for patient safety, for medication safety. And that's what they're really asking us to do. So at this, I kind of went over a little bit, but if anyone has any questions or comments, this is the time. Thank you so much. Sure.
I have a quick question.
Yes.
Thanks for the excellent presentation.
Yes.
Eye-opening presentation. Are you guys aware of any data out there that electronic prescribing
Yeah, I can take that. So you're correct. Electronic prescribing with the HITECH Act was one of the measures that facilities had to implement, and as of this year, we're just getting to it between this last past year and this year. Facilities are now finally getting to full, and as of January, many places have done that, where a discharged patient or from a hospital setting has electronic prescription going there to the retail pharmacy or the dispensing pharmacy, or even from a clinic. So most of you, although work in pharmacies, but you know you receive electronic prescriptions, controlled substance for sure, but even the other ones. So slowly you see that is phasing out. So what I will tell you is this: the data is preliminary and partial in terms of how much it is, but it is increasing. And you have already seen the implementation of CPOE, the computerized physician order entry system, took away the errors that were related to illegible writing, handwriting, or incorrect way of putting up Y, I, or L's, and U for unit, etc., abbreviations. That have gone away, and that data is present. When you're talking about electronic prescribing from hospital or clinic to pharmacy, that is also on the same trend, believe it or not. And also because it's going from system to system, and eventually it's going to go through the healthcare exchanges, which some of you guys may know, and I won't delve into that for now, but the data will show the same exact trend which you have seen with CPE, that is minimization or decrease of errors that are related to incorrect transcription, incorrect telephone verbal orders, because now physicians putting systems, incorrect spelling, or even writing prescriptions that were happening, that were causing that, and handwriting, etc. So it's the same trend. Does that mean all 100% of those errors will be reconciled? Maybe not, because somebody will still choose a wrong med and from the system, and that will continue to happen. But if you were to ask on the big picture side, yes, the trend is showing the same exact thing. Does that answer?
Yeah.
Okay. Any other questions?
Wonderful.
Thank you so much for having us. Thank you.